So we're going to talk about AFib. So what's AFib?
Atrial.
Okay, so atrial fibrillation. So what does fibrillation mean? What are the atria doing?
It's jittering.
It's just, it's fibrillating like a pile of jello on a plate. It's just sitting there, okay? So if we have our heart here, I already told you I'm not an artist. Okay, and we've got the SA node and the AV node, right? So the SA node is in charge and they send out electricity and they say, okay, AV node, it's your turn, like a relay race, right? So then the AV node goes, okay, cool, and they send out electricity and then everything contracts, okay? And right before, remember when the ventricles are filling? And then right before we contract, the atria go, oh, I have some here. And they squeeze the blood that they have into the ventricles, giving the heart 30% more cardiac output. Okay, so they give a really nice amount of blood to the ventricles to pump out to the rest of the body. Okay, so that's called the atrial kick. And that's increased blood volume, okay, to send out to the organs. Okay? So in AFib, the SA node, I don't know what it's doing. It might be sending out electricity, maybe it's out to lunch, I don't know, but the leader is not doing their job anymore. But something's got to happen, right? The heart has got to pump, it needs electricity. So there's a cell over here that goes, oh, I'll do it. There's one over here that goes, I'll do it, I'll do it, I'll do it, I'll do it. So pick the analogy that you want. Pick me, right, from Shrek. Or mine from Nemo, whichever one you want, they both work. Everybody's trying to be in charge. That means they're all sending out electricity. And the AV node is like, whoa, I can't handle it. What are you guys doing? Where did the SA node go? I can't handle all of this stuff. Oh, okay, but I'll take that one. I can handle this one and I'll send it out. So periodically the AV node will catch some electricity and it will send it out, okay? So if this is now fibrillating and because there's electricity going all over the place, and we don't have a nice contraction anymore, what happens in here? What happens if an organ just sits there like this and isn't pumping the blood around?
It just sits there and pools.
It pools, okay, blood pooling. Why do we care about that?
Clots.
Clots. So it's just floating around in there making clots. Okay? All right. So that is how AFib works. When we're looking at an EKG and we're looking at the complexes, the shape and all that of the electricity, everything that looks the same is coming from the same cell. So if we draw another heart here, now instead of everybody wanting to be in charge, the SA node, the SA node is still out to lunch. But there's a bully in the group. There's somebody that's like, oh good, now I can be in charge. And they're amped up on energy drinks, and they're just high on life, right? And they're sending out all this electricity, and the AV node is still, oh my God, what are you doing? Where's the SA node? And it just keeps sending it, and the AV node will capture some and send the electricity through, okay? So this is a flutter. As far as we're concerned, they're pretty much the same thing. A flutter has a very specific shape. It looks a certain way. The P waves look like shark teeth, okay? And they'll call it sawtooth. It looks like the blades of a saw, that kind of thing. But the reason that these P waves look the same is because they're all coming from the same cell, okay? So the doctor could take that person to the cath lab and they could zap that problem cell, and now that's gone. Now the A flutter is gone. That's called an ablation, okay? And so these are all of the electricity coming from that trouble cell, and then when the AV node catches it and goes, okay, I've got one, then you have your QRS. okay? And your T, well, you're not gonna see your T because this one's like, okay, come on, go, 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 and it's still sending them out, and so you're gonna have more. Okay, so then you can't really see your T wave. It looks like all P waves. And then they'll say, well, there's 3 P waves to 1 QRS, so it's a 3-to-1 flutter. Okay? So that's a flutter. AFib is really what we're gonna focus on though, because a lot of our population is geriatric and has chronic illnesses and AFib. AFib is everywhere. I don't know if you've noticed yet, but so many people have AFib and it's life-threatening, okay? So there's a few things that happen with AFib that are a problem. First of all, you have less cardiac output, right? Up to 30% less cardiac output. So if we're talking, just to give it some perspective, if you have 6 liters of blood, 30% of that is like 2 liters, right? One point eight, okay? So instead of pumping 6 liters of blood through our body, we're only pumping 4. You know, I mean, that's a huge difference. So we talk about perfusion. So we may go into renal failure because we're not perfusing the kidneys well, right? Because we're only pumping 4 liters out, okay? And cardiac output is per minute. Our heart is very busy and incredible, okay? So we could go into renal failure. Our heart's gonna work harder now, right? Because it's not perfusing the rest of the body very well, so our hearts can suffer, so we can have cardiac problems. What does our heart do when it's not working really well? It beats faster, and over time, it does what?
Doesn't the muscle get bigger?
It gets bigger. The heart's like, oh my God, we're struggling, what can we do? Ooh, let's bulk up. But it doesn't, the muscle doesn't increase, it just gets big and floppy. It doesn't get like big and muscular and now my heart is like a tank. No, it gets big and floppy and like, I'm just big and floppy now, right? So we call that cardiomegaly.
There you go.
It is not an effective way to pump blood. And if you look at an x-ray, instead of the heart being like this, it's like this. And you're like, wow, how are they breathing? Because it's taken up space, right? That muscle's got to go somewhere. And so now they're potentially having respiratory problems because their heart has gotten bigger. They're not pumping things as well. So you can see just that, just the atrial kick piece is a problem. So our patient is going to be tired, right? Okay, so because they're not having that much oxygen, they're going to think, oh, I'm tired because I'm old. What is the problem here with the clots? Why do we care about that?
You can go to the drain.
Yeah, they're going to go to the brain. Clots are going to travel. They're going to go as far as they can until they get stuck. Where's the other place they go? The lungs. Yeah, so you're either going to have a stroke or a PE. Both life-threatening. Stroke can be a permanent disability if they don't, die. Most people that have strokes don't die. If it's from a clot, they're permanently disabled, which is, for some people, worse, okay? And then a PE, that can be, you can die from that suddenly. So clots, that's a big problem. So how do we treat that?
Blood thinner.
Blood thinners, okay? What kind of blood thinner, what's the standard blood thinner for AFib? Warfarin or Coumadin. So when you see, if I just put an AFib rhythm up, you should start thinking elderly, blood thinner, tired, risk for stroke and PE. Just from looking at that strip. That should just be a normal response. That's what you should picture in your head. Betty, or whoever it is. I was talking about Betty earlier, right? So warfarin. Now, What's the problem with warfarin?
Risk for
It's a
bleeding.
blood thinner.
Risk for bleeding.
Risk for bleeding. And what do old people do?
Bleeding.
They fall down. So we have now an increased risk of injury from falls, right? So increased bleeding. So they could come in with a brain bleed instead of the stroke from a clot. The other thing that's really common is they'll come in with a GI bleed. We can't take them off their blood thinner. They have to be on a blood thinner because the risk of a stroke outweighs the risk of bleeding. Okay? And then there's a whole set of things that go along with warfarin that you'll need to know. Okay, like how we manage it, how we dose it, how we teach about it, that kind of stuff. Okay? So AFib, the P's are all coming from different places, right? So your P's all look different, which is why you have this weird, if non-existent P waves. So you can't really count them, you can't really measure them, because you can't really identify what's a P, what's not a P. You could have P's in your QRSs. What's the one thing that is kind of characteristic of AFib? Other than the P's?
They're different?
Irregular. So if you were to come to me with a strip that kind of looked like AFib, but all the QRSs were really regular, we would be thinking twice about it. I'm sure it's happened. But AFib is generally irregular. Okay? So these are the main complications. As far as the heart rate and when you're in the hospital and you're acutely ill, the rate is a problem. So let's say that we're getting all this electricity, right? And the AV note's like, I'm gonna do this. And I'm not gonna just take this one, right? Okay, I'm ready. And it's gonna catch more. And what's the rate gonna do? It's gonna go up. So we already don't have a good cardiac output. It's gonna go up for a little bit, but we have this big old floppy heart that's trying to do all this stuff. It's not gonna last long. We call it AFib with RVR. So AFib with RVR, rapid ventricular response. Means the ventricles are kind of keeping up, okay? And we're talking 160, 180, maybe more, okay? And then we treat it with, generally this patient is gonna go to like PCU or ICU, and we can, we're gonna give diltiazem or cardizem. IV, it's gonna be in a drip to try to get everything under control, and then we can always put them on a pill. The other one that you'll see that's really old, but the NCLEX really likes it, is digoxin. So it's just one of those things. It's old. It's maybe not as good in some cases as diltiazem, but if you have an old person that's on it and it works, don't mess with it. Lots of research, we know exactly what the problems are and how it works, and there's a level to draw and all that good stuff. Okay, so that's another drug that you're gonna have to know well. And then the other thing we can do, if it's new onset, we can cardiovert. So you can hook them up to defibrillator pads, and you can cardiovert them and try to kind of take all those little cells and go, come on, get together, and shock, and then hopefully they will all kind of now come, and one person now will, one cell, hopefully the SA node will kick in and get back to work. Okay, so the super important stuff, AFib, what it looks like, it's irregular. The P's may or may not be able to be identified, but you can't measure a PR. Sometimes you have a T wave, sometimes you don't. The atria are fibrillating, so we have a potential problem with clots. This is probably one of the most important things, is the warfarin. Okay? And then they have to be on something while this is kicking in. This takes about a week, 5 to 7 days, I think, to become therapeutic. So you need to know what therapeutic is. And then they're gonna be on heparin or Lovenox until the minute the INR is therapeutic. Okay, and these are all things that you're gonna be learning and looking up, and you'll come back to me next week and be pros on this. You're gonna know everything about it, and you're gonna be happy that you know everything about it. Then we also have the fact that we're losing a large amount of cardiac output, which is going to affect, we're gonna be tired, it's gonna affect perhaps our kidney function, we might develop some cardiomegaly, some heart failure if the heart can no longer pump the blood forward and now it backs up into our lungs. And so respiratory can be an issue, okay? And then risk of stroke and PE. So when you have a patient with AFib, you gotta monitor for signs of stroke and signs of PE, right? And then this would be an acute complication, AFib with RVR, that we can treat with IV medication until we can get it under control, and then we can give a maintenance PO for at home. Okay, questions about, I just kinda wanted to give you a little bit of an overview.
Where it says atrial kick and it's increased blood volume, right?
Blood volume.
So how come on the then decreased cardiac output? Is it the same?
So cardiac output is heart rate times stroke volume.
Okay.
Stroke volume is the amount of blood in your heart.
Oh, okay.
So if I have less amount of blood in my heart, it's a multiplication problem. Heart rate times less blood is gonna be a smaller number,
Okay.
right? So you're gonna end up not pumping as much blood, because the atria usually donate a little bit of blood with every beat to the ventricles.
That's already, you say, there.
Yeah, it's collecting in the atria in a normal heart, and then right before the ventricle's filling, right before it goes to pump, the atria go, oh, here, take mine.
So in that case, it's not doing that.
It's not doing that. So now all you have is whatever's filling in the ventricles.
Oh, okay.
Okay, so it's potentially 2 liters less,
Okay.
which can be a lot depending upon the situation. And the size of the person, you know, little old Betty, she's all of like 80 pounds, right? And now she's down a couple liters. She might be in trouble. Or 500-pound Kenny. I'm just making these things. He's got to pump a lot of volume, right? He's got a big area to fill. He's going to be in trouble as well. Okay? That's good.
Yep. Bye.